Welcome, everyone. Thank you for taking time to join me today. I'm Dr. Joel Schacher, and today I'd like to share not only how I use Pitts21 brackets, but more importantly, why I chose this treatment philosophy and its protocols. Like many orthodontists, my approach has evolved over the years. Every one of us begins our career treating patients the way we were taught. But as time goes on, we all reach moments where we ask ourselves, can I make this better? Can I make treatment more efficient? Can I create better smiles and a better patient experience? For me, that journey eventually led me to Pitts21. Well, I'll share with you today, what I'll share with you today isn't simply a review of a bracket system. It's the clinical journey that brought me here, the successes, the lessons learned, and the principles that convinced me that this was the right direction for my practice. My hope is that whether you are already using Pitts21, considering it, or simply curious about another treatment philosophy, you'll come away with practical ideas that you can apply in your own practice. After treating thousands of patients and spending years teaching orthodontic residents, I've learned that it's often the small changes in treatment philosophy that produce the biggest improvements in outcome. Well, without further ado, let's get started. Before we get going here, I'd like to share with you a little bit about myself, some professional information, and some personal interests. I graduated dentistry at the University of Toronto in 1977. In my era, you didn't have to have an undergrad degree in order to get to orthodontic school. So I actually don't have a Bachelor of Science. After 2 years of undergrad, I went into dental school at the University of Toronto, and then ultimately on to Eastman Dental Center in Rochester, New York, where I got my specialty diploma in orthodontics. Tropical orthodontics is my practice, and it was established in Mississauga, Ontario in 1988. For those of you who aren't familiar with Toronto, that Mississauga is a large suburb of Toronto on the west side, population about 1.2 million. And a consultant has told me over time that this is the largest concentration of orthodontists in any area that she's ever been into, other than Houston, Texas. There's about 50 orthodontists practicing in Toronto, Ontario. I have a large history of memberships in different organizations. I'm a life member of the Ontario Association of Orthodontics, which is a sort of a component or division of the Great Lakes Association of the American Association. I'm also a life member of the American Association of Orthodontics. I'm an active member of the Canadian Association of Orthodontics, and I still serve on the executive of the Ontario Association of Orthodontics, having been its president from 2023 to 2025. I'm proud to say that I am the captain of NAN, which is the National Advocacy Network for the province of Ontario, part of the AAO. And I'm currently a clinical instructor and professor at Eastman Dental Center, or now Eastman Institute for Oral Health, teaching Pitts21 beginning in 2024 to the present class. So it's my third class of students teaching them Pitts21. I'm married to Terry. I have two great children. Neither one of them is in dental. Both my children are in advertising. My son is the executive vice president of a company that does the marketing for all of the pharma industry in Toronto, and my daughter Gabrielle also is in advertising in California. Two of my greatest loves are collecting, so I'm an art collector and a collector of baseball memorabilia. If you were in my house, you'd be able to see all the artwork all over the house and all the baseball memorabilia in my office. Anytime you want to visit Toronto, I'm happy to have you over. And if you're a baseball fan, I can probably give you a whole history of baseball, both in the United States and Canada. I love all sports, especially baseball and basketball. So my favorite teams are obviously the Toronto Blue Jays and the Toronto Raptors. And due to the proximity to the NFL in Buffalo from Toronto, great fan of the Buffalo Bills. I am an amateur bartender and make all kinds of cocktails all day long. This interest was renewed during the pandemic, where we would meet friends online, and we would have a drink of the day. We would show them what was needed in order to make the cocktail. We would go through a list of hors d'oeuvres so that we could have the same hors d'oeuvres. And so they would be on one side of the computer, or everybody on the meeting on one side of the computer. We would be on the other side, and we'd sort of simulate being in a cocktail party together because we all had the same food and we all had the same drinks. Love a good single malt as well. And our area where we live, which is on the west side of Hamilton, Ontario, a small town or smaller town west of Toronto, is about 45 minutes from wine country. In our wine country, there's approximately 90 wineries. So we're often there on the weekend, and we're there twice this last weekend, visiting 3 wineries on the Saturday and the Sunday. In this talk, we're going to talk about our journey to Pitts21 and what got us here, why I recognized the need to change in my practice and change the philosophy of practice that we were doing. Going to give a recent history of self-ligating bracket design and those self-ligating brackets that I've used. We're going to talk about the difference between considering the face and profile first as compared to tooth first treatments, which is a sort of a more older modality. We're going to talk about considerations in designing orthodontic treatment. And I have 10 case examples and one bonus example that if time allows, I'll be able to give you at the end of the presentation to show you some of the applications of the Pitts21 bracketing system. So like everything, there is a story here. And it all starts with asking better questions, listening to the answers, sort of listening to the questions and the answers and trying to figure out what it all means, discovering what really matters, and then using that to deliver excellent care. Like in all stories, it all starts with a castle and a walkway. This one probably no different. Okay. Once upon a time, there were 4 bracketing systems. That I used the speed bracket system from 1980 to 1989. My original practice was in Hamilton, Ontario, where I associated. And the inventor of the speed system, who was Herb Hansen, he was a Hamilton orthodontist. Most people don't know that. And so almost everybody in town were using the speed bracket system. And one of the things we sort of learned about the speed practice system is that it required great expertise to place it. That placement was everything in this system. And so at that point in time, I started putting on my own brackets. And believe it or not, 45 years later, I still put on all the strap-ups myself. We're thinking approximately 15,000 in total. After 1989, we switched to a mini twin, which was produced by TP Orthodontics called the Tip Edge. And we used that for 15 years from 89 to 2004. In 2004, through a series of events, the rep that I had for TP Orthodontics became a rep for Damon and for Ormco. And so I ended up switching to the Damon system in 2004, taking a few courses, and I've used many of the Damon brackets, Damon 2, Damon Hybrid, Damon MX, Damon Q. By the time it came to Damon Ultima, I was already out of the Damon system and into Pitts21. I did not use the H4, although that was a precursor to the Pitts21, but I obviously used Pitts21 and Pitts Pro, which I'm currently using. And what I found was the application for the Pitts21 bracket system was a lot farther reaching than anything I had used before and gave me great treatment latitude relative to doing conservative work for people. Obviously, an evolution is needed. So somewhere between the new grad on the left, that little monkey down there, and the guy with the briefcase, that's where we all reside. My goal is eventually to get to the guy on the briefcase. I don't know how realistic that is. I think I'm somewhere between the guy with the stick and the guy behind. And it's interesting, the guy behind obviously has no clothes. And sometimes when we're working and we see things that we don't understand, we feel that we're fully unclothed. But obviously, moving forward and trying to do better work all the time is something that we're all after. So how do we put all these pieces in the puzzle together? How does it evolve into a treatment that gets better all the time so we can do the best work for our patients that are usually possible? The greatest obstacle to discovery and change is not ignorance, it's the illusion of knowledge. Sometimes we think we know so much already, and we're so inundated with articles and journals that we block ourselves off to learning about new things and trying to see how those new things apply to current treatments and how they might be an evolution of the treatments that we learned about back in school or in the early years of our practice. We try to move from the caterpillar to the butterfly, although somehow I don't think we ever get to the butterfly. We're usually in the drawing in behind, just the butterfly coming out of the cocoon. That to be a fully developed butterfly and fly away, I think is something that we all strive for, but very few of us ever get to. There needs to be an aha moment somewhere along the line when things click, when we start to see things for what they truly are and realize that perhaps some of the premises that we were working on before may not be ideal. There may be a need to change. Some of these things are very obvious. They're right in front of us all the time, yet we don't stop to pause to take a good look at it. And for me, that occurred around the 20-year mark when the patients that I had treated had their own children, and now I'm examining the kids. As I'm examining the kids, I'm looking at the parents that I treated, and if I don't like what I see, I'm thinking to myself, did I cause that? Is there something that I did to cause those people to look differently than what I had hoped for, than what I had envisioned? This is a sort of a cover of a Time magazine in August of 2004. And although its purpose is to look at how you can get to be 100 years old, I sort of took it to look at the evolution of a face over time. The young gal on the left with a beautiful profile, beautiful skin, lips intact, face intact. And then through time, as we develop more lines, we develop sagging at the corners of our mouth, lips that maybe don't look quite right, mid faces that collapse in. Those are all things that I'm noticing now and caused me to sort of think that I needed to make some change. So in orthodontics, obviously, we're looking at people's mouths all the time. So the first thing is for us to sort of notice and document what happens to the aging mouth, what happens as we get older. So a few of the things that we notice are the lips get thinner and longer. There's loss of elasticity in the area around the mouth. The vermilion border gets blurred, so there's not great definition between the lips and the rest of the face. And the corners of our mouth start to droop. In this picture, it sort of indicates all of that. You can see the beautiful display of teeth in the lips and the mouth on the upper right-hand picture, that beautiful set of lips on the lower left, and on the lower right, the loss of the vermilion border, the sagging of the corners of the mouth, all the lineage, all those things that we take for granted every day that we see, that perhaps maybe in orthodontics, we can work a little bit to delay. We can't prevent it, but we can perhaps delay it and maybe have it look a little bit less. And in conjunction with the lips, what happens to the rest of the face? Well, our vertical face height decreases. That we have less display of upper incisors as we get older and a greater display of lower incisors. And so what I usually tell my patients is, if you're lucky enough to have a grandfather with all of his teeth and he smiles, most of the time you just see all of his lower teeth. You don't see any upper teeth. They're hidden by the upper lip. And if you have a 10-year-old boy in your family who just got his upper teeth in and he's running around and smiling, you only see upper teeth and you don't see any lower teeth. And so our brain equates upper incisor show with youthfulness. And so we can create a more youthful smile by having the upper incisors dominate. It makes people look younger, and that these days is what people want to have. And then naturally over time we get overclosure, whether it's due to loss of teeth, whether it's due to wearing of teeth, those sorts of things. And so those are four primary areas where people have a situation where their face declines. This is sort of an illustration of that, where we can see a well-defined profile on the left. Things look like they're in proper proportion, and then that same face later on ages, and you can see how our nose and our lip become more prominent, our midface caves in. We end up in a situation where the vertical is decreased. And again, this doesn't just affect our diet and our speech, but it also makes us look a lot older. If we're going to plan orthodontic treatment relative to the incisor position, these are the considerations. The upper incisors are positioned is critical to the lip support. That upper incisors in the canines should form an arc that mimics the curvature of the lower lip, typically referred to as smile arc. And the larger question is, are facial aesthetics better served through extractions, jaw surgery, or neither? This is just an indication as to how the upper lip supports both the upper lip, the upper tooth position both supports the upper lip and lower lip at the same time. And those are the things that we're looking for. So what actually makes a beautiful smile? What are the elements of the smile? These are some of the things that we know. That we want to have a full smile that's fully formed, so there's no dark corners at the side, no dark triangles. We want the upper incisors to be perfectly vertical, both looking at it head on and from the side. So our eye sort of detects about a 5-degree variance between upper incisor angulation, either forward or backwards. Anything larger than that, the patient feels the teeth are not in the right position. And then naturally you want to have a proper amount of gingival display. I think this is the hardest part of all, is that somewhere between 2 and 3 millimeters of gingiva. The good news is, with aging, even if we have a little bit of excess gingiva, that seems to resolve itself over time. But obviously we need to have some goals, and so proper gingival display is one of them. Again, key attributes of a great smile: beautiful smile arc on the upper left, facial symmetry on the lower left. The teeth should be even and symmetrical in the smile. And then naturally, a good smile also involves a great occlusion, where all the teeth fit, front and back, and there's a proper angle of the front teeth. We all know Julia Roberts, Anne Hathaway, and Jessica Alba, excuse me, and they have a lot of these attributes in common. So you can see the beautiful smile and the smile arc on these three ladies. The little bit of gingiva that's displayed, maybe about 3 millimeters in each of these cases, and a full smile where there's no dark corridors at the side. So originally, I know when I first graduated that we used the teeth to plan the treatment and not so much the face. I remember being in associateship and having a patient that was extremely dished in with severe crowding. And the senior that I worked with, we would look at all the cases together and we would co-treatment plan. And so in this particular case, what I said to the senior was, I'm uncomfortable taking out teeth because I think that person's face will get further dished in. And what he told me was, well, remember, they've come to you to straighten their teeth. And so that's what they expect. So in this case, we're going to have to straighten the teeth in spite of the face. And I think those ideas have changed dramatically at this point. So all of this knowledge that we've accrued to this point, how do we apply this knowledge and offer up-to-date treatments to our patients? One of the things we do know is to accommodate crowding, we need to broaden the arches. And a little bit more about that shortly. I wanted to show this case that was presented by Dwight Damon. This is not a Dr. Damon case. This is a case that Dr. Damon used to show this idea about tooth first treatment planning. So this particular gal, you can see she's a teenager at this point in time. It was done, the initial photos were done in 1977, so quite a long way back, almost 50 years ago. And you can see that, she has a relatively good profile. Not the best, but it's relatively good. I do not have the internal dental slides on this particular case, but I will be able to show you the final result. So this is her in 1977, and this is her 25 years later. I want you to notice a few things relative to her teeth, that there are 4 bicuspids removed. There is return of crowding in the lower. There is irregularity of the dental alignment on the upper. The overbite has reappeared. But most importantly, if we look at her facial profile, you can see the severe dishing in of the profile. Her nose and her chin are in one plane and her lips in another. The lips have gotten much thinner over time, as we talked about, and much longer. That on this particular x-ray here, or excuse me, photo here, you can see the protrusion in greater detail. That this is the left and right buccal. You can see the overjet and the protrusiveness of the upper teeth. I think it's more sort of fallback of the lower incisors. Again, a closer view of the upper and lower teeth and the return of lower crowding and upper sort of rotations, we'll call it. So in spite of the extractions, there wasn't stability in the case, but there was facial decline. That I remember attending a lecture many years ago and being told that the most stable spot for the teeth are the ones they came to you in before they started, which means they're in balance between the lips and the cheeks. And so that's why they are where they are. So once we start to move teeth in orthodontics for better aesthetics and better function, we need to realize that steps need to be taken in order to maintain them, because we're moving them out of a place of better balance to a place more likely of less balance. More about expansion and expansion versus adaptation. We'll talk about both of those things. So as you remember in your high school math, that this is all about pi. Not these kind of pies. I wish it was these kind of pies. And at the end of this presentation, there'll be my email address. I'd love to receive some emails from all of you listening to the webinar as to what your favorite pie is. I will tell you that my favorite pie is the key lime pie, the one on the lower left. But I'm curious in this survey to find out what you guys love and enjoy. If you remember your high school math, you remember pi times the diameter of a circle is the circumference. And our teeth, they fit on the circumference. Good thing that a broad, wide smile is in vogue these days, because if it isn't, then we would have a lot more trouble creating some of these things. That originally, the only way to get expansion was through a rapid palatal expansion device or something of this nature. Just to let you know, I'm not a big proponent of RPE, and I haven't actually used an RPE in my practice for over 25 years. All of the cases I'm going to show you today and the way broad smiles have been created, none of them used an RPE at all during their treatment. That's just me. Everyone's welcome to use what they feel is right. One of the reasons why I don't use an RPE is the potential for some periodontal issues around the abutment teeth. And studies have shown that when using an RPE, there's a greater incidence of recession later on the abutment teeth than the general population. As opposed to rapid palatal expansion, that light forces through an appliance like Pitts21 or even the Damon system use passive forces. And so there's remodeling of the dental alveolar process. And so there is less likelihood of recession. There are all kinds of CBCTs that have been taken to show this. I'm not showing that today. We just don't have time to go through this. That would be good for another lecture, another seminar. Okay. This is an example of an article. This particular study shows that there's unwanted periodontal compression and root resorption. RPEs reduce the buccal bone thickness and induce dehiscences on the buccal aspect. So this is just one article that showed up in an AJO. This is another example of that, where it says, although there's net gains to be achieved with RPEs, there is significant expansion relapse. And I wonder about that, because sometimes RPEs are used in the upper arch where there isn't a crossbite, just to get width. And then perhaps a Brody system, a Brody syndrome is created, or something like that, where eventually the cheeks lay back onto the buccal surfaces of the teeth and cause recollapse of the width that was achieved. So for me, I needed to find something that when the person wasn't in crossbite, how I could get extra width, both the upper and the lower at the same time. Just another study. This is an example of the Pitts archwire template. And so you can see the archwire comes in several widths. The blue is the powder blue is the largest or widest width, the plus plus, and there's a Pitts broad plus and a broad. The standard arch form, which is the purple one in the middle, is more for the arch 4 appliance. So we're not going to talk about that one today. I can assure you that if you're using the Pitts bracketing system, and for those of you who have, you know, if you put in a blue arch wire, your teeth don't get to be that wide. But it's the sort of the, we'll call it the drawing out of the arches that is achieved as we go along using some of these broader arches. Excellence is not a skill, it's an attitude. You have to want to get better. We actually don't develop this without trying. It's something that you have to strive for. I think what it really means is we have to be our own greatest critic. Once we start thinking that all the work that we do is great, then I think sometimes we stop learning. So we need to be a little bit more humble and to make sure that we're always on the path to learn. Back when I started to do the Damon system, which is about 23 years ago now, we were actually going crazy in the office. We were starting to see things that we didn't expect, things that we didn't understand. And my staff would say to me, I think you've lost it. And what I would say is, well, I don't think I've lost it. There may be a small hole at the bottom of the bag somewhere, but I haven't lost it entirely. And this enthusiasm for better treatment is carried on into the Pitts21 system or the Pitts Pro system, which I find is so excellent in doing all these things that we always wanted to do. Just a quick journey into my office. This just shows the reception area on the top right. We try to make people really comfortable. We have some great artwork on the wall. This is art from a street artist in New York called Create or Kevin Vigil. All of these are very modern kinds of pictures, and I find the kids in the waiting room looking and trying to interpret them, which is a great thing for some of the patients to do. You can see in the plants, we have lots of plants in tropical orthodontics all over the office, trying to create a tropical atmosphere. The picture on the lower left is the consultation room. On the left side of that picture, there's a dental chair where I would normally sit with a patient. This is an area where the TC and the parents sit. And that TV screen on the far wall is a large screen TV that we purchased a frame around from China that allows that screen to be transposed into a touch screen through the Epic Pen app online. And we can draw and do all sorts of things on that to create some kind of an experience for the patient and the family. It isn't uncommon for the TC to work on financials, where I grab the child, bring him to the screen, and we play a game of X's and O's. I usually let the child win. That's better for closing of the case. Again, in the middle, I'll close up of the waiting area with that planting area, and then another area waiting on the right side, which is in front of the photo studio where people go to get their photos taken. So on our journey from Superman, or from Clark Kent to Superman, I usually tell my staff that this is me, Superman, and they say, no, that's an S for Schacher. I said, okay, whatever. But we're moving from the left to the right, trying to get there. That's a long distance to go. So what about face first treatment planning cases? What do some of them look like? So in the next few minutes, I'm going to go over 10 examples of our treatments using Pitts21. I'm not going into great detail on the strategy involved. Again, I don't have enough time in this presentation to go over that, but if OC would like me to do that, I'm happy to go over some of the treatment planning in detail for you to see how we staged it and how we planned for it so we can get the outcomes that we achieved. I told you that I was an amateur bartender. And so if we were meeting in person, I would say it was time now to take a break and go to the bar and have a cocktail, perhaps. But if you guys are ever in Toronto, I'm happy to entertain you at my home and take you to the bar. We can share stories about orthodontics or anything else and have a few cocktails. Um, that anything you would like. My bar is fully stocked. I can make anything that you wanted. Let's start off with a class 3 open bite case. I think these are the things that we like to look at as far as difficult cases that can be treated more easily with an appliance like Pitts21. This case number 1 has a story involved with it. This patient was driving to me all the way from Ottawa. Ottawa is the capital of Ontario. Actually, the capital, yeah, it's the capital of Canada now that I think about it. And it is about 5 hours of a drive from Ottawa to Toronto. This is a patient that's driven all that way because he had 4 consultations in Ottawa. All of them were orthodontic surgery. He had heard of our office through Dr. Duncan Brown, who obviously is one of the prime Pitts users and researchers for Pitts21, who practices out in Alberta. And Dr. Brown was kind enough to send him our way and to do treatment for him. This case was completed in 14 months because when you're driving 5 hours, you are the best patient that you could possibly be. If you look at the slide here, it depicts the problem to begin with and the finish. Let me go through that in a little bit more detail. This is a close-up look at the case. You can see how narrow the arches are, upper and lower. The class 3, if you look at the let's say the right and left buccal shots, you can see how class 3 he is, especially on the right side, and then the wide open bite with the tongue in the middle. This is actually a set of photos from the pan repo stage because I can't show you all the photos, but we did take photos every single appointment. And you can see that this treatment is coming along. We're pretty well class 1 on the left buccal, and on the right buccal, still significantly class 3. This is the final. What I want you to notice is that on the, let's say, the lower left picture, which is the right buccal, you can see the reddish area on the cuspids at the gum line. Same thing on the left buccal. That's because during retention using Essex retainers, we were using clear buttons on there with a light elastic to try to keep the bite closed. We did that for a year before we took the buttons off. So this is a year after the case is finished. It's pretty stable, as you can see, and it's worked out beautifully well. Again, from the center, the way things look, you can see the upper occlusal and the amount of width that we achieved. I know it's not calibrated, but you certainly get the idea as to how much width was achieved without an RPE. There are lingual buttons involved because we were using through the arch elastics, and that's pink triad that we were using for temporalis squeeze exercises to help close the bite. Again, can't go over the details of those right now, but certainly drop me a line, ask me about it. I'm happy to sort of go through some of the steps with you personally. In the lower, we naturally use tongue tamers to help control the tongue. And oddly enough, you can see on the right picture where the bonded wire is, we also for a time had the tongue tamers re-cemented back over the bonded wire. So in the early stages of retention, the tongue tamers were actually there. The right buccal shot and the occlusion that settled. The left buccal shot. In this picture, we don't have full seating of the occlusion on the left side. Drives me crazy, but he's driving 5 hours, and so we felt that would be okay. I tried to equilibrate that afterwards, and I think we were pretty successful in doing that. So that's the end of that particular case. Second case is a class 3 tendency case where there were undersized laterals, and as part of the treatment, the lateral incisors were built up. This case took approximately 17 months. Okay. You can see from left to right, the before and after center smile shot. This is the original problem. You can see how everything is skewed. Her lip is skewed as well. You notice the pig lateral on the lower, on the right buccal shot Also a smaller lateral on the left buccal shot. Both of them were built up to be the same size. This is at the pan repo stage. You can see now we have anterior turbos there, some lingual buttons for using through the arch elastics, and you can see that we don't yet have an occlusion. This is the final shot. Occlusion is all locked in. Teeth are now centered pretty well. Got a nice smile that's been developed. And if you look at the left and right buccal shots, you can see the buildups of the lateral incisors. So every case that we do gets a Bolton analysis before we start. So we know if there are any tooth discrepancies, because you can't get a proper interdigitation of teeth if the teeth are the wrong size. And at the same time, you can't get a proper overjet and overbite. So just to go through this in more detail, you can see the center shot and the comparisons, the occlusal and the comparisons, lower occlusal, right buccal, and you see the buildup well of the upper right lateral incisor, left buccal, upper left lateral incisor. In the next case, I wanted to show you a multi-phase case. This is interesting because this is the daughter of one of the fellows that I did when I took the sort of the Pitts Masters course. The father was one of my two cases, and so this is the daughter. Phase 1 and phase 2 took a total of about 30 months. Okay, I'm just going to break the two phases down together. So again, this is the left side is before we started doing anything. Youngster, right side is after phase 1. So you can see the anterior crossbite. Although she's not class 3, we did run a face mask. We got her to this position. And then in phase 2, we fully strapped up everything using brackets on the upper and lower incisors and molars, and using Bernie tubes by Dr. Raoul Bernstein on all the other teeth. The Bernie tubes that we used, they're little tubes with little hooks on them, able to run elastics and everything. So we got a really good head start. So this is after phase 2, just prior to going, after phase 1, just prior to going into phase 2. So on the left is our beginning, and on the right is our end. She did come out a little bit gummy, unfortunately, but they were very satisfied with it. So this is the strap up in phase 2. You can see strapped up for smile arc as we're coming to the end. And then this is the final. Nice profile, everything fully locked in, good class 1 occlusion, proper overjet and overbite, upright incisors. I think this worked out really, really well. You can see the comparisons. So if we go on the upper left, down that side, and then the upper right, down that side, that's the order. Here, something similar. Unfortunately, it's across because it's the occlusal, so across the top and across the bottom. Same thing here, across the top and across the bottom. This is our right buccal. You can see from top to bottom on the left, but on the right, you can see as we go along. And if you notice, the hook on the upper cuspid is flipped over because we needed to tuck those cuspids in. So the beauty of the Pitts21 system, as those of you who use it, is a lot of the anterior brackets, including the cuspids, can be inverted to get opposite torque. We just don't invert the lower cuspids because we don't want to risk recession. Again, this is the left buccal, the same. And so I think this is a very, very successful treatment. One more open bite of this older lady. This is a treatment that took approximately 24 months. You can see, again, class 3 open bite-ish kind of a treatment going from left to right. This is the right buccal shot, and you can see how class 3 she is, and her mandible is actually shifted to the left side by the positioning of her teeth. This is the middle shot where the brackets are. This is shortly after pan repo. You can see she's still in anterior crossbite here. And now this is the finish. So occlusion fully locked in. We did set up for a molar implant. on the left. That created a little bit of a challenge to settling the posterior occlusion on the left side, but it worked out beautifully well in the end. She was a very good patient. That's the anterior portion. So you can see what that looks like. This is the occlusal. Again, pink triad to help close the bite, doing temporalis squeeze exercises. More on that at another webinar. This is the lower. Notice we use bonded wires in all cases. Right buccal occlusion, fully settled, fully class 1, and upright incisors. Same on this side. Class 2 Division 2 case now with this young gal. This is a case that took approximately 23 months to do. Going from left to right, we can see the development of her smile. This is a beautiful case, by the way. I'm actually quite proud of this case. Okay. You can see the crowding, class 2 crowded, done non-extraction, using Pitts21 arches to expand the upper and lower arches. Okay. You can see how the expansion is starting. You have blue bite turbos, you disclude to allow for the expansion. And that's the finish. So in detail, you can see the anterior portion. We have a full smile, everything nice and broad, centered, healthy gingiva. Upper occlusal, and again, although we haven't calibrated this, you can certainly get the feeling to the amount of width and expansion we achieved in this particular case. Same thing on the lower, that expansion. This is the right buccal. You can see the case is fully locked in. This case did use a class 2 corrector for a short time in the middle. I used the CS5 spring by Dentaflex. Works beautifully well. Left buccal. This next case is a class 2 division 2 case. And you can see the smile develop. This is an interesting case because shortly after debond, this person moved to Korea. So I have not seen them actually for 2.5 years. So I don't know what happened to her, except we got the brackets off, saw her for a short time after, and then she moved. But you can see from left to right. This is the original sort of array of photos. You can see the arch shape on the upper and the lower, the way the teeth are so out of line, the cross bites, the class 2. This is I think is a pretty difficult case to be done conservatively. You can see the strap up. This is a pan repo. Naturally, some of the repo was done in the upper incisors to get those teeth in the correct angulation, and then lots of IPR later. This is the finish. Worked out beautifully well. I think in retrospect, I wish I could have gotten a little bit more width, but it's still beautifully broad. I'm not complaining about it. That's her face. I think of really importance is her profile. She has a well-balanced profile. Everything looks great. I actually love this profile. It's perfect in many, many ways. I mean, perhaps later on, maybe she would decide that she needs to alter her nose position a little bit, because I did realize that her nose is a little bit off center as well. This is the center shot. Got the midline on. The upper occlusal and its evaluation, and there's considerable width that was achieved here. I wish I could have got a little bit more, but her physiology wouldn't allow it. This is the lower occlusal. Left buccal. Everything settled and nice. Right buccal. Looks great. Very happy with this case. I think it worked out beautifully well. From a significant class 2 div 2 case to a class 1, I think it looks really good. And we did get the upper incisors upright. Class 1 case. I love the way the smile developed here. We'll go into it in more detail, but this is the original set of teeth. You can see the sort of the shape of the upper arch, the angulation of the upper and lower incisors. We are class 1 already, but we need to develop a better smile and a better show of teeth. So this is in between. brackets placed on for smile arc development. This is at the pan-repo stage. Like I said, lots and lots of pictures in all these cases, but unfortunately, and I think you can tell I'm talking pretty quick here, they've only given me an hour to go through this. So again, either for another seminar or if you're interested, just give me a call and I'm happy to review any of these things with you. This is the final. I think it came out beautifully well. This is a beautiful smile. Improvement in the profile. That looks excellent. Center picture. You can see how we show all of the teeth. Upper occlusal and a significant change in shape and width. Lower occlusal. Right buccal. Everything settled. Left buccal. One more class 1 crowded case. This one took about 21 months to do. You can see from left to right. Development of the smile. So pretty difficult case, lots of crowding, significant crossbite on the left side. Just a lot to do in this particular case, but all done with Pitts21 and no expanders. So this is going into pen repo. You can see we've already got the arch shape. We did use differential wire widths here, a plus wire on the top and a plus on the bottom rod. That actually helped in relieving the crossbite. So with disclusion and turbos, that really made it quite easy to get him out of crossbite. This is the final shot where you can see the occlusion, the frontal smile picture, everything looks beautiful. I think this is a really nice case. Nice healthy gingiva, everything looks great. We did some IPR to get rid of the dark triangles, things like that. What I usually tell my students at Eastman is obviously we're all dentists first. So in my work, there isn't a single tooth in the mouth usually that isn't touched by a drill, whether it be for IPR, reshaping of edges, bite equilibration. We do everything in the office before the brackets are removed. So every tooth gets a drill, takes a little bit of extra time, but I think it causes a really beautiful result. And also a little bit of laser surgery doesn't help. Excuse me, doesn't hurt. Freudian slip. Here's the upper occlusal with a wire there. Lower occlusal, see the lingual bonded wire. Right buccal. Everything in occlusion, and again, upright incisors, and that's really important to me. Left buccal. Little bit of sort of, we'll call it not fully seated occlusion in that 2636 area where there was the crossbite. Just couldn't get that part, but I think more than acceptable. One more crowding case. Last one. This case took 14 months. It was relatively quick. So flat smile arc to begin with, nice smile arc in the end, and the middle is the bonded wire picture. So you can see all the crowding. You can see the lower cuspid out of position, the 3-3 out of bone. So lots to do here. I think that 3-3 is out of bone due to the crossbite. So that obviously needed to be corrected. And then all the other elements that we've talked about so far. This is the pan repo stage. You can see the blue turbos on her teeth. You can see the crossbite on the lower, we'll call it on the left buccal shot is corrected. Starting to get the upper teeth upright. We have, and like in some of the other photos, we have the upper anterior brackets flipped over to create negative torque so we can upright the teeth. And again, that's the final. They look pretty good, I think. Beautiful smile arc developed. This is the result. For me, I think that 3-3 is a little bit forward still, although inner mouth, it's hard to tell. Just in this one picture, it looks a little tiny bit forward, but not as forward as we started. You can see that picture compared to the picture on the top left if you look at the cuspid. And interestingly enough, some of the recession has improved because the root of the tooth is tucked into bone. There's been no surgery on that case. Upper occlusal, nice arch shape. Lower occlusal, again, a very nice arch shape, looking really good. The right buccal, how we've evolved into a nice occlusion. Again, upper incisors upright. Left buccal. And I did want to include the profile here. I think we have a fairly nice profile that's occurred. It's the profile to begin with was reasonable, but if you look at the difference between the two, you can see we've got a lot more lip projection, and the lower lip has rolled down a bit to make it a lot thicker, and a lot of women actually like that. This is a case that I really enjoy showing you. It's actually quite interesting because this is the son of a referring doctor, referring dentist. So in this particular case, this case did take approximately 24 months. This is how the case presented. And I kid you not, this is what happened. The dentist drops this patient off. His name is Jordan. Drops Jordan off at the front door and says, I know you did this case without extraction, and leaves. And leaves. And here we are stuck with the patient thinking, oh, this is a big deal, big deal. Well, we're going to put our knowledge to use and see if we can get this done. So this is how Jordan presents, and you can see he can't even smile because those cuspids are holding his lip up like that. He has a lot of modeling, things like that. And so we're going to get that sorted away later on, hopefully with the help of Dad. But this is a particularly interesting case. I want you to watch the profile because I think this is really important. This is at the pan-repo stage. So all the teeth are fitting, and he's in class 1. Couple of things of note. The upper incisors are really proclined, has actually caused his lip to be, his profile to be very protruded. So he has a very convex profile right now, which obviously we don't like. But again, the mandate from Dad was no teeth out, right? And so this is Jordan, how he is at pan-repo stage, which probably is about 8 months after we start. This is his final. So you can see we got the profile to calm down. That we got a little bit of laser work done, although I like more laser work to be done. We got his teeth whitened. Doesn't hurt for Dad to be a dentist, although I would have liked Dad to do more. So in general, this has become a great case, and also he can smile well. We have a little bit more gingiva than we would like to show, but I do think that the lateral incisors, they need to be lasered a little bit more, and that would actually help with this. I don't think they've been lasered enough, but Dad did the lasering, not me. He didn't allow me to do any of that stuff. He said, oh, I'm the dentist. I can do the lasering. Okay, then. So you're not going to argue with one of your top referring doctors. We do from time to time check the occlusion. That's where the blue marks are, and everything is okay, just to make sure that that he's not biting on anything. I have a funny feeling that we did replace, let's say, the upper wire at some point, maybe on this visit, and that's why the blue marks are there, just to make sure we're not biting on the wire. Okay. But I think he came out quite well. So again, this is the before and after, and there's no question how much broader he got. If you take a look at that, where the upper eye teeth had no room at all, the lower eye teeth had no room at all, and now we have ample space for them. This is the final. So we're able to get the upper and lower front teeth upright. We had inverted the upper brackets, and we did a ton of IPR. So like I said, every tooth gets touched by a drill. So some IPR, some reshaping the incisal edges of teeth, and occlusal equilibration to make sure that everything fits. So there was a lot of work here, and that's why it took about 24 months to do this case. This is the left buccal. And again, you can see how upright we got those upper front teeth. So if we're looking for an appliance that gives you absolutely great control, that's why I love the Pitts21 appliance, because I feel that engagement for third order, for torque, is really, really important in this. And if you see on the upper, not only did we invert the upper incisors, we inverted the cuspids as well, just to get everything tucked in. So I think that worked really, really well with this application. Okay. That's the lower occlusal, everything fitting. That's the right buccal. good occlusion, upright incisors. You can see how much those incisors traveled. It's crazy what they did. Upper occlusal. And so that ends this round of cases. But I do have one more. So at the most recent meeting of the Pitts Progressive Study Club in Reno earlier this year, an opportunity to present this case because I thought it was unique, and Dr. Pitts wanted me to present it because it's the same case treated twice. So this is a case that I treated back in 2010 with the Damon system. It was with Damon MX. You can see the brackets here. The anterior turbo is already doing that, but the brackets were placed at FA point, not at the incisal edge. That was the final result, and I could not get the upper teeth upright. You can see how they're still proclined. We did get good width though. She returned to me back 11 years later in October of 2023, and the upper teeth were even more proclined, saying, I think my case, I think my teeth have moved. We talked about retreatment, and a month later, we retreated her with Pitts21, or started. This was a 10-month retreat that we did. And you can see the brackets are placed for smile arc. This is the final, really beautiful broad arch. Those upper teeth are now upright. That's the right buccal. That's the lower occlusal, upper occlusal, left buccal, and then the comparisons of smile arc. So the Damon system with the brackets placed at FA point with a flat smile arc, and then the typical beautiful smile arc created by smile arc protected bracket placement in Pitts21. But the journey continues. So after 45, actually now 46 years of orthodontic treatment of patients, I still feel there's so much more to know. The more you learn in this field, the less you seem to know. So it's time to move forward and continue to explore. That Pitts21 Pro is a disruptive technology. So it's time to always create and never conform. We are doing things differently with this technology than others do. It is controversial, but the proof is in the pudding, and I think the work that this technology achieves is dynamite. And so we continue to use it and explore as to different applications for this. The greater our knowledge increases, the more our ignorance unfolds. So the more we learn, the more we realize how little we knew to begin with. And so exploring new techniques and gaining new knowledge, attending more seminars, things like that is really an important part of practice. This is my contact information. You're welcome to contact me at the office or by my mobile phone. If you want to call me on my phone, then please text me first, introduce yourself and let me know. Otherwise, it's going to go to spam. My phone tends to screen out scamming calls. As an instructor, as a teacher, as a clinician, I feel this is really appropriate. Wise people plant seeds for trees under whose shade they will never sit. So we're teaching students to do orthodontic treatment. And often the time we lose track of them and never know how they've become, what they've become. I'm proud to say that I have a student that recently presented at a half-day meeting in Manhattan about some of the work she did at University of Rochester using her Pitts21 systems. She's a new grad, and I think her work is equivalent to some people that have been out for decades, certainly better than I would have done 20 years out. So I applaud her, and I take great pleasure in teaching kids like this. This is my contact information again. Again, the Office of Tropical Orthodontics. You can send me a message anytime there. My mobile phone, please feel free to use it. Drop me a line anytime. Certainly want to know about your pies and things like that. Chuckle. And so let me leave you with the following thoughts. Orthodontics is constantly evolving, and I think the best clinicians never stop learning. My treatment approach today is the result of 45 years of asking questions, trying new ideas, and always putting the patient first. Every Every case teaches us something different. The day we stop learning is the day we stop growing, not only as orthodontists, but as clinicians. I hope something from today's presentation helps you on your own journey. Thank you so much for joining me today. I appreciate your attention. And as I said, I'm only a phone call away. I'm happy to receive your phone call anytime. Have a great day and good luck in your continued practices.